Well, welcome everybody. Thanks for joining us today. Next slide, please, Ryan. So happy Immunization Awareness Month to everyone. We wanted to kick off this special month by offering some education sessions. My name is Mary Ellen Casey. I'm an infection preventionist here at Health Centric Advisors and the moderator for this session. So we're really happy to have you today. A few housekeeping items. Today's session is being recorded. And we really encourage you to participate via chat, but we ask that you please keep yourself on mute during the presentation. Have questions ready. We will be taking questions at the end of this presentation. So as we've mentioned, please introduce yourself and share as you feel comfortable your name, organization, role, where you're from, using the chat feature. Next slide. So I'm sure most people know how to use Zoom, but just in case, you can access the mute, video, and chat options at the bottom of your screen in the black bar that shows the icons. Next slide. We are the IPRO QIN-QIO. We're a federally funded Medicare Quality Innovation Network, quality improvement organization in contract with the Centers for Medicare and Medicaid Services. We are one of 12 regional CMS QIN-QIOs nationally. IPRO services New York, New Jersey, and Ohio. Health Centric Advisors covers the New England states, and Clarent covers Maryland, Delaware, and the District of Columbia. Next slide. So we're really excited about today's presentation, addressing vaccine hesitancy, getting to yes. We have two great speakers today, and I'd like to introduce them. Our first is Dr. Yassine Aboul. Dr. Aboul is an assistant professor of medicine and researcher in the Division of Geriatrics and Palliative Medicine at the Warren Alpert Medical School of Brown University. He is an ABIM board certified physician in internal medicine and geriatrics, an ABIM board eligible physician in pulmonary medicine and infectious diseases. Dr. Aboul's research focuses on pulmonary vascular diseases and respiratory infections, with particular emphasis on vaccination effect, risk stratification, biomarkers, and health services research in long-term care settings. Dr. Stefan Grabenstein is the David S. Greer Professor of Geriatrics at Brown University. He has served as Director or Chief of Geriatrics and Palliative Medicine in 3 academic institutions and now leads that division at the Alpert Medical School of Brown University. Dr. Grabenstein's long-standing interest has been in immunity, inflammation, cardiovascular outcomes, and aging, especially in the context of infection. He has typically researched these through the lens of vaccines, antibiotic stewardship, and quality improvement, especially in the long-term care setting, and are a topic of the majority of his publications. So we're really excited and welcome. So Dr. Aboul, I'll have you take it away.
Thank you for the introduction. So let me share my slides. It's not allowing me to share actually.
Dr. Aboul, are you able to hit the share button at the bottom, the green button?
Yeah, I'm hitting, but it's not allowing me to share.
How about now?
Yeah, still not allowing. Maybe you can share for me.
Oh, yeah, we can wait a second.
Okay, perfect. So those are our conflict of interest and disclosures. So I received and I'm receiving some grant fundings from CDC and pharmaceutical companies. And Dr. Gramestein also is receiving grants and fundings from other pharmaceutical companies. Next slide, please. Okay, so let's look at this slide from our belief perspective. So
I think we have polling questions first. Let's, we're having a little lag here, so I'm,
yes, a little bit like, yeah.
okay, is polling question, can we put that up?
It's live.
Okay. What is the main reason to say no to a vaccine? There's choices. I see you guys are starting to vote. Worrying about side effects. What other people tell me? I don't trust the science. I don't understand the fuss about risks. I worry about long-term effects after vaccine. And we can see from this that, I don't know if you can put that screen up for the results of the poll. So about 40% say I worry about vaccine side effects, and the 45% I worry about long-term effects after vaccine. Thank you. All right, Yasin, back to you.
Okay, can we go from the first slide, please, Ryan?
Yeah, it's I'm getting lag here, so
Yeah,
I don't know.
I'm getting lag as well. Yeah.
So Ryan, do you want to present the slides? Can you do that? Maybe you won't have the lag.
Yeah, not a problem. You guys see this okay?
We see the conflicts of interest slide, so that's good.
Yeah. Which slide would you like me to go to? Right here?
Sure.
Oh yeah, learning objectives.
Put it on
By the
slide.
way, it's not allowing me to share, so still, but we can
Can you
get
put
help.
it on slideshow? Click that button at the top. There you go.
Awesome. All right. So today we will learn all together, actually, and you will learn and you will understand cognitive styles for the vaccine education. And by the end of this presentation, you will be able to identify effective strategies to improve vaccine acceptance. So we will go over the presumptive and participatory language. Next slide, please. So let's look at this slide from our vaccine acceptance and the vaccine hesitancy perspective. So this slide shows our beliefs arise from subjective, emotional, and psychological reasons. And our beliefs for the vaccine hesitancy and acceptance are affected from environmental factors as well. So our family can change our minds, our friends can change our minds, and colleagues. So our work environment also can encourage us to get the vaccine. And after forming our beliefs from the point of vaccine hesitancy and acceptance perspective, so we then defend and justify and rationalize them with intellectual reasons. But the key point is our beliefs are formed by environmental factors, family, friends, colleagues, and the culture and society at large. So, and our beliefs comes first.
And one of the ways I think about this, Yasin, is that when we think about the people around us and, you know, it's our kids or our parents or whatever it is, the decisions they make, they influence how we think about this. And when we watch the news, you may know this from watching politics, you tend to believe the things that confirm your own beliefs. You have an affirmation bias.
Yeah.
And so the belief leads, and then you try to explain your beliefs and justify them, especially when there's a lot of pushback.
Yeah, exactly. I agree. I agree. So I think that that's all about the culture, environment, family, and external factors. And then we start to defend our beliefs and justify them. And explanations are following the beliefs first. Yeah.
Yeah, and so in the nursing home, for example, I'll have a staff person that would be more likely to accept the belief of one of her coworkers that they trust than necessarily a scientific explanation that I might have to offer.
Yeah. Yeah. That's same for the parents also. If they were educated by their parents for the vaccination, they vaccinate their own kids. So great, thank you. So next slide, please. So this is a very striking slide, actually. So this is from coronavirus tracker, which is not available currently. So tracker as of April 13, 2024, we have over 7 million SARS-CoV-2 deaths in all over the world. Could you please hit again?
Those are the deaths we know about.
Yeah, those are from all over the world, actually. For about the US, next slide. Okay, so when we look at the US, so the first confirmed death was on February 6, 2020. It was in Santa Clara County, California.
Next slide.
Next slide, please. And since then, we have more than 1.2 million deaths.
In just the US.
Just this is the US, and we are a country taking all these statistical analyses very well, actually.
Next slide.
And next slide. So this is a slide is showing combined total American military deaths in World War One and Second and other conflicts, and it is about approximately 600,000. Next slide, please. So when we look at this slide, we can see more Americans have died in 4 years from COVID-19 than all these conflicts in total. Next slide, please. So this slide shows the definition of the vaccine hesitancy and the vaccine acceptance. So for the vaccine hesitancy, so this is a state of indecision, and the people who have vaccine hesitancy have some delay in acceptance, and even they may have some reluctance to vaccinate despite the availability of the vaccine services. And when we look at the vaccine acceptance definition, so vaccine will be there and available, and the ones who are willing to get vaccine, they will go and take it. So there is a hesitancy in one part, and from the point of acceptance, and there could be some reluctance to vaccinate despite of the availability. Next slide, please. So why is vaccination is important, and why is vaccine hesitancy is important? So when we look at this slide, you will see some numbers. So the vaccines prevent 3.5 to 5 million annual global deaths. That's why the vaccination is important from the point of preventive strategies. And there is a study that showed from mathematically US COVID-19 vaccination program itself prevented more than 3 million deaths and more than 18 million hospitalizations between December 2020 and November 2022.
Just in the US.
Yeah, this is just in the US. And when we look at the vaccine hesitancy, why this is important, you can just put the top 10 global health threats, and you can just check from the WHO website, and you will see this is one of the most important health threats because it's causing misinformation, confusion, and it's preventing all these numbers, actually, if it is the case. So other ones, actually, climate changes and the antibiotic stewardship, microbial resistance, so on and so forth. But this is very important from the point of these global health threats. Next slide, please. So let's try to have some concepts for the vaccine hesitancy. So as you can see from this slide, and we have some components for the vaccine hesitancy. So first one is the cognition, our thoughts, our beliefs. And on the other hand, we have also feelings. So this stands for the affect, and also our behavior will impact on vaccine hesitancy. So choosing to get vaccinated or not. So this is all about coming from our behavioral approach as well. And when we look at the decision-making habits, so we will just check risk and benefits, and we will decide accordingly. So those are the main components: our thoughts, beliefs, feelings, our behaviors, and assessing the risk and benefits as well. And this vaccine hesitancy will be affected and influenced by also other complex issues. And one of them is complacency and perception of the low risk of vaccine preventable disease. So we may say, or you may say, this is not a threat. So we may underestimate the risk of higher exposure and the higher risks. Another one is a convenience, which is not a problem in the US, but it could be an easily problem in other countries, developing or underdeveloped countries, accessibility and availability of vaccines. And the confidence. So I think this is the most important part. Trusting the system, trusting the policymakers, trusting in vaccine itself, and knowing the side effects and the long-term effects. So those are the components which may affect the vaccine hesitancy. Next slide, please. So when we say vaccine hesitancy, we will have some challenges, and we had some challenges as well. So when we look at the literature, so this literature is showing 32% of adults, almost 1/3 of the adults, were hesitant to get vaccinated right away. So they did choose wait and see approach. So that they preferred to observe how the vaccine worked for others, and then before deciding to get vaccine, they just said, I will wait and see the next steps. I will wait and see. So this is the one of the challenge in vaccine hesitancy. Next slide, please. So I will go over with next 2 or 3 slides about factors influencing the vaccine hesitancy one by one. One of them is the internal factors, and I will try to make some examples for that one. And Dr. Garwenstein, feel free to jump and contribute as well. So one of the title is the internal factors. So we may have knowledge, we may not have knowledge also. And we may have information, we may not have information, and we may have misinformation, we may have mixed information, we may have disinformation as well. So we will go over those definitions as well. And our past experience can affect the vaccine hesitancy as well. So someone may have side effects, someone may have heart attack from vaccine, so which is very rare actually, and someone may attribute the vaccine experiences to vaccine itself, which might not be true. And another one is perceptions. So perceptions is also very important for vaccine hesitancy from the internal factors.
So there's some of that comes from what we directly observe, so if we are at work and somebody gets a vaccine and suddenly they look sick the next day, we may automatically assume they're sick from the vaccine, but it might just be bad timing of luck. But when we see that, we might then just assume that it's the vaccine that's causing it and then perceive that as our own personal risk. It's the same way when you hear about an airplane crashing, that suddenly you feel it's unsafe to travel. And even though travel by air is the safest way you can get about if you're going to use a motorized thing. So this risk perception is something that's very personal and something we do every day without even thinking about it.
Yeah, so imagine a case who has a immobility and some kind of underlying problem for the venous thromboembolism. And let's say that case, that person received a vaccine within 3 weeks, 4 weeks, but we have other reasons for the predisposition for the venous thromboembolism. So we can, that case, that person can easily attribute the upcoming or already done pulmonary embolism to the vaccine itself, but there are other factors can affect the venous thromboembolism. So it could be coincidental finding and perception and maybe misinformation, or mixed information as well. And other ones are religious and the moral convictions. Those are also strong factors can affect the vaccine hesitancy. Next slide, please. So when we look at the external factors, so public health and the vaccine policies, so they may help, they may sometimes not help actually. And so the way the public health authorities present the vaccination acceptance and the vaccines is very important also. So we will talk about in later slides about that one. And also vaccine policies are affecting vaccine hesitancy. And the healthcare professional recommendations, this is the most important part. If, as a healthcare professional, if we recommend vaccines strongly, it was shown that it helps for the acceptance. And also communication and the media portrayals and what everybody else is doing. So this is from the point of social norms and circles and what the other peoples are doing.
And also what you get through where you get your news, if you get it through Twitter or Facebook, as opposed to from a independent news source.
Yeah, that's a great point as well. Yeah, so those are the external factors. For the next slide, we will see the psychological factors. So conspiratorial thinking, so conspiracy theories. So this is very, very effective and also affects the vaccine hesitancy, maybe number one, and in some part of the world, even in the US, and significant predictor for the vaccine hesitancy. And reactance means, so reacting to the vaccine recommendations. So somebody may have resistance being told what to do. So that could be that somebody's personality. And this is called in psychology reactance. And high disgust sensitivity. So disgust toward blood and needles. So it was shown in the literature that the ones who have high disgust sensitivity may have vaccine hesitancy. And the last one is individualistic and hierarchical worldviews. So when we say this one, individualistic, so those people may have self-reliance and they are not collective per se. So they just look the vaccine acceptance and vaccination from the point of their own interest. For example, they don't care about the collective approach and herd immunity and prevention for the next pandemic, so on and so forth. This is also a psychological factor. When we look at the hierarchical worldviews, so those people look at the upper levels. So they are leaders, they are religious leaders or political leaders or societal leaders. So this can affect also vaccine hesitancy very well. Next slide, please. So those are some definitions from the point of misinformation, disinformation, and mixed information. So when we say misinformation, this is shared false information without intent to mislead. So sharing a wrong vaccine side effects and without any intent. So this is a misinformation. When we look at the disinformation, it's a false information, and this is created to mislead. And that could be a coordinated campaign spreading false claims about the vaccine, and that can cause some problems for the public trust to the vaccination. And mixed information, that this could be true or false information. So, for example, a social media post can easily give a true information about the accurate efficacy. But on the other hand, if they put some false side effect claims, it can affect our vaccine acceptance and hesitancy as well. Next slide, please. Yeah, so impact is, at the end of the day, on vaccine confidence, vaccination rates, increase hesitancy, and reduce public health outcomes, which we summarized before. Next slide, please. So when we look at the US vaccination status and intent, this is a striking slide as well. You will see here probability of getting vaccine, and whenever we ask this question, probably or definitely will not get vaccine once will be higher. So we are seeing here 41% will not get vaccine, COVID-19 vaccine, and 29% will not get the RSV vaccination. When we look at the definitely will get vaccine once, so we will see here 8% and 9% percentages. Next slide, please. And this is from CDC website, and it shows the percentage of nursing home residents who are up to date with COVID-19 vaccine, and the range between 20 to 40%, and by the end of July, it is still around 30%. So next slide, please. So then we have to ask to ourselves, are we doing a good job from the point of preventing the vaccine hesitancy? Or we can ask this question differently: are the governments and the public health authorities are doing good job from the point of vaccine educational efforts? So the answer from previous slides, we can easily say, I think no, because they are just adopting unimodal fact-based information. So we will see what I mean in the next slides, and it is not changing vaccine acceptance. So the factors influencing vaccine hesitancy comes from our cognitive styles. So if we see world differently, cognitive styles are going to be affect our vaccine acceptance. And this may not align with the intended recipient's preferences. Next slide, please. So basically, healthcare decision-making success actually based on the healthcare provider's ability and skills to share the information, adapt the information, and to present that information in patients' own words, and educational efforts should be tailored according to the patient-centric approach.
So what you're saying here, Yasin, is that if we keep presenting information the way we're presenting it, just applying them with data, since that hasn't worked, we are not doing it in the way that the people who are trying to get vaccinated will be accepting of vaccine. So we have to change how we present the information.
Exactly.
Yes.
Exactly. Yeah, I think that's a great point. So if we just give the numbers, percentages, it is not going to work for some of the people, maybe most of the people, and we will show how it works right now. Okay, next slide, please. So this is a slide which is showing 6 cognitive styles for vaccine education. One of them is denialistic. Next slide, please. Next slide again. So when we say denialistic ones, so those ones, so they don't accept scientific facts. So we have those kind of expectations, relatives, and maybe friends. And despite of the overwhelming evidence, they're prone to believe conspiracy theories. And they can say, I don't care the data, I am not interested in to see the data, I don't believe vaccine is safe. So the way we should approach these people is we should repeatedly give the messages with the motivational interviewing approaches. So when we say motivational interviewing, we should avoid the hard selling per se. And we can start with a sentence that I know I understand your concerns, and I just want to discuss with you why you don't want to be vaccinated. And then we can address and we can get more information about the vaccine hesitancy, and we can lead the conversation accordingly.
Yeah, and you might not ask the question why, because it might sound like you're going to try to talk them out of it, and instead phrase it more like, what are your thoughts about vaccines in general? What experience have shaped your perspective? And the idea is to engage them in a way that they can talk about what they see as their own drivers. And it might require that you revisit this, not just on the current visit when you're trying to suggest that they get vaccinated, but that it happens over a series, and that you think about what would make them reconsider it. So what makes them think about a vaccine as getting them something that they value, as opposed to getting something that's just maybe they think it's going to cause harm and just going to cause harm.
Yeah.
So the idea that, and I'm going to give you a correctly stated fact here, is the idea that COVID vaccines prevent death. This person would not be swayed by the fact that 98% of the people who have died from COVID were unvaccinated. The vaccine is that effective, but that wouldn't be a convincing feature for them. Something that might be convincing would be a softer sell. For example, if this allows them to join the other folks by not being masked when some other activity is happening. So some other thing that they consider a value, this trade-off. So you have to figure out what that trade-off is, and you have to sort of solicit from them sort of what their drivers are for this. So asking it as a why may not be the best way, but asking about saying what. What do you think do you think about this, and what do you think about vaccines in general, and sort of tackling it that way?
That's a great point. So I think also acknowledging their concerns, starting the sentence with acknowledging their concerns, it would be another opening sentence.
Yeah,
So,
this can be a sensitive subject, and I want to talk about this respectfully.
Yeah.
So they know that you're going to be advocating for vaccines, but giving them room for their own voice.
Yeah, and another recommendation from this article also, so we should not dismiss their thoughts as well. So we should put them in the center and take it from there. Okay, so next slide, please. So the second one is enumerate cognitive style. Next slide. And so those ones cannot understand, or they may have difficulty to understand the numbers. So they can be fixed for the numbers, and they can say 1 in a million risk sounds high for sure. I will be the 1 in a million risk one, and I will have the side effects, and I will avoid the vaccine. So that's why the approach for these ones, we should not provide any mathematical information, but we can do some analogies, and we can compare, and we can avoid medical jargon most of the time. So that helps them to understand the reasoning of the vaccination. But if we go more about the mathematical information, so they may not get the reasoning of the vaccination as well.
It reminds me of that Dumb and Dumber scene with Jim Carrey, where the woman he likes doesn't want to have any part of him, and he says, "So what's the chance I could have a relationship with you?" And she says something to the effect of, "Not 1 in a million." And he looks at her with a big smile. So I've got a chance, and clearly not getting what this means.
Exactly. Yeah, that's a great example. All right, next slide, please. So the fear-based cognitive style, so they go with their fears. So, and they say, I heard vaccines are harmful, I'm not going to get them. So again, I think we should understand the reasoning of vaccine hesitancy is the fear-based, and we should go into the details of that fear and what's the source of fear. Is it coming from misinformation, disinformation? And we should also persistently and continuously provide the positive approach, and we should show the risk of comparison to other daily life activities, and we should emphasize on the risk of not receiving vaccine is the another problem. So because they have fear base, so that can help if we say about from the point of not receiving vaccine will cause harm, so that may affect their vaccine acceptance habit. Next slide, please. So heuristic cognitive style, so they have mental shortcuts. So most of the time they bypass the detailed analysis, and their processing skills are not on the table, and so they can do some verbal expressions, and they can just go with the very low number of flu vaccine side effects, for example. So they can say, I remember Guillain-Barré syndrome happened in 1977 and after flu vaccine, and that must be common, and therefore I'm not getting a flu vaccine. So this is also another problem for the heuristic ones, and often they appeals to availability of heuristic approach. And so we can take this opportunity to make it more educational for them, and we can provide educational materials, and we can also say some facts about the vaccine. But this is the hardest ones we can handle also. So the mental shortcuts can affect the vaccine hesitancy at that point.
And an example I gave you a little while ago was like if you read about an airplane crash and therefore you don't want to get on a plane because you think airplanes must be unsafe. The mental shortcut allows you to generalize this event, which is a rare event, as if it were a common event. And the other example we gave was if you can prevent 98% of people from dying from COVID that otherwise would die with a vaccine. If you see somebody dying after a vaccine, which is one in millions, the mental shortcut that the vaccine can kill you is the one that gets you into trouble, because it's way, way safer to get a vaccine and have a side effect than to get COVID, absent vaccine, where you have an unchecked infection that who knows what it's going to do, which could give you long COVID or kill you or put you in the hospital, but often doesn't do any of those things, which is what people observe, and they do the heuristic that COVID must not be such a big deal.
Yeah. Next slide, please. And bandwagoning cognitive style. So they are primarily influenced by the others, and they do what the others do and what the others say. And so verbal expression for this one, if others are refusing the vaccine, there must be something. So I'm going to skip getting the vaccine. And the approach to solve this problem, first, we should identify and understand the primary influences. So we should understand they are actually doing or saying what the others say and do. And we should point out logical inconsistencies and understand these sources, and we can educate them from that standpoint as well. Next slide, please. So this one is the analytical cognitive style, and they use left brain thinking. They believe in facts, and numbers are very important for them. And all in the CDC website and in the literature, so we can just share all this information with them. This is the easiest one, actually.
Your
Because,
Department of Health does it this way.
yes, exactly. So they provide the data in their website, everything, so we can just pull that data and provide that data requested and review analytically. We show some nice graphs, so on and so forth, and they will accept. So this is the easiest way, analytical way. Next slide, please. Next slide. And next, please. So this is the one is showing, actually, which I tried to explain with the help of Dr. Gravenstein about learning styles. So it's coming from left side and right side. When we say left side, they like upright, planner, rational, logical, precise, realistic, and they like numbers, actually, and they go with the logic, they go with the knowledge and cognition per se. Next slide, please. Yeah. And the right side style, they go with the emotions. So that's the ones we should work on and also develop some styles to convince them. It's not easy to do that actually. Next slide, please. So when we look at what works, as I said before, strong recommendation by healthcare worker and healthcare provider will be the number one. If we strongly recommend the vaccination, it will work. And nursing home visits with personalized education, motivational interviews, which we try to explain you how to do that, actually, with some examples, and reducing patient out-of-pocket vaccination clinics. So this is particularly important from the point of nursing home vaccine hesitancy and acceptance perspective. So that can be coordinated with DOH, and because they will see somebody is going to be vaccinated and other ones will get vaccine, so that can affect their habits and thinking process in the nursing homes. And reminders, recall systems, those are good one, but apparently they are not helping. And implementation of the vaccine-related anxiety education program. So if we reduce the anxiety, so we will succeed to get more vaccine acceptance. And the standing orders for nursing home residents is another one. And quality metrics, if we make it as a quality metrics, it will be very helpful as well. Next slide, please.
Wait.
Oh, wait. Yep. All right. So I just want to ask here to Dr. Groenstein, and how would you like to do your vaccine decision today? So would you like to get the COVID-19 shot today or not? So how would you like to?
You know, I don't know. Maybe when I come back the next time, let me think about it some.
Okay.
So
Okay.
what's wrong with that? Okay, go ahead.
Yeah. Is this a good approach? Is this a good question? Next slide, please. I think which we just played is showing presumptive or participatory language. If you say, what would you like to do about your COVID-19 vaccine today? Or if you say, how do you feel about getting flu shot today? Those are not helpful. Those are participatory language. And as a healthcare provider, we should avoid this language, because our aim to get that person to be vaccinated and prevent vaccine-related diseases, right? So presumptive language So we should say, you are due for flu and COVID-19 vaccination today, and we will give you these vaccines before you leave today. It was shown that presumptive language increased the vaccine acceptance. So that's the bottom line of this slide.
So the participatory language makes it sound like you're asking them for their own opinion about this. And you want to indicate that you have an opinion about it as you're offering it, that this is something they should do. So
Yeah.
this is not something where you want to invite a discussion, although you're open to a discussion. It's a situation where you're saying, I'm recommending you get this vaccine today. And the way you do it is you're going to get this vaccine on your way out the door in clinic, or we're going to be giving you this vaccine. It's time for it. Let's do it.
Yep. Next slide, please. Yeah, as I told, these studies consistently show presumptive language is more effective than participatory language. A strong recommendation should come from healthcare provider. Next slide, please.
So when you're thinking about this at for example, in a nursing home, you have strategies to improve uptake within your facility. And one of them is you create this expectation that you have a standard recommended vaccine that you do as part of good care. So when patients are admitted, you should set it up so that your vaccines are part of your standard of care. If you have annual vaccines, that they are, as they come in with their admission orders, say, we're going to be giving you your flu shot every year. You should know this is coming around. And this will be happening in the fall along the lines of what the Department of Health and the CDC recommend. And this should get you around trying to do annual consenting. It should be a standing order and a standard of care. Within the staff, there should be this knowledge that these vaccines are communicable diseases. They are infections that staff bring in, that family members bring in, and the only way you can stem this, keep us from getting our patients sick, is by saying we're expecting that our staff get vaccinations every year, and if they're not for these communicable diseases, that they're wearing masks or doing some other thing to keep them from unwittingly spreading it. So COVID vaccines, flu vaccines, RSV vaccines all reduce the risk of getting infected in the first place. And if you don't get infected in the first place, reduce the risk of spread. Some do it better than others, but it begins with when we emit virus, that once we're infected, if you're vaccinated, if you get infected anyhow, you'll just spread less of it. And so the load you give to the people you infect will be less, you'll get less sick, and you might be able to prevent it altogether. So this culture of vaccination starts heading off the risk of having these outbreaks occur in the first place. It protects us from each other. It cocoons our residents from each other by getting them vaccinated. And it protects us from short staffing, something that we all have problems with in nursing homes. So part of this process is not just a culture of vaccination, but also being accountable for that culture, meaning that we count and we advertise within our facility what our success rate is and what our goals are. You can't improve what you don't count. So if you have 50% uptake among your staff for vaccination, your goal should be something that is somewhere between 80 and 100% for staff and 80 to 100% of residents for the vaccines that you're promoting. So whether it's a COVID vaccine or a flu vaccine, or for your folks that are in the nursing home 65 and older, or an RSV vaccine, those should be the target goals you set. And if you know what you hit last year, your new target should be some higher number than what you got last year. You saw that 40% of folks are declining to get COVID vaccines. You know, you're going to have COVID outbreaks. I'm sure you've had more than one. You'll have more of them. This is the only way to prevent that propagation of COVID within your facility. And still, even though far fewer people are dying if they've gotten prior vaccine, you can still keep them out of the hospital and keep them from getting sick and preventing long COVID if you keep them up to date. So count it, set targets for your uptake, set aggressive targets, because aggressive targets get you better improvement in those outcomes than in just any old target. Next slide. Next round of polling questions. Can you put those up, Ryan?
Yes, would you like me to just start from number 2 and go on, or just as a specific one?
You should have two sets of polling questions. One was the first group and then the second one. Yeah, just we can work if they're put up one at a time, you can do one at a time. That's fine. Okay, what is the key factor improving vaccine acceptance according to recent studies? Reducing vaccine costs, strong recommendations from healthcare providers, increasing vaccine availability, using participatory language. The key factor is what's the best way to improve uptake? Okay, we're going to end the poll now. We have 43 of 90. We have still lots of people that need to vote, need to weigh in. We can't tell who you are, so if you haven't done it, just do it. It's anonymous. Okay, so you can see strong recommendations is the correct answer here. Not participatory language, but strong recommendations. Okay. Okay, next question. Is there another polling question?
Yep, I'm trying to. Someone is trying to control. I'll do it right now.
So the which language approach has been shown to be more effective in increasing vaccine uptake? Presumptive language, participatory language, both are equally effective, neither is effective.
Most effective increasing vaccine uptake. Let's end the poll. So Yasin, you want to talk about this?
Yeah, so the presumptive language is the correct answer actually here. So sounds like participatory is better, right? But let's make it clear. If you start with a participatory language, how would you like to get your vaccine today? Would you like to get your vaccine today? And or so those are gonna degrees of the patient's vaccine acceptance. But if we start with the presumptive language, so looking to the computer and you are due for flu shot today, and before you are leaving, we will get flu shot to you and we will close that page. So this is a presumptive language, and it was shown that presumptive language increased the vaccine acceptance rate. Next poll question.
Which type of educational material would most likely influence your decision to get vaccinated? Detailed data and statistics, personal stories and testimonials, visual aids and infographics, social media campaigns, interactive tools. So this is about you personally. What drives your decision?
I can see the left brain ones.
We have a left brain audience.
Yeah.
So here you have it. So most of you prefer detailed data and statistics. That's, of course, what we learned in school, right? But some of you like the personal stories and testimonials, and you've seen by our presentation style today, we've been doing a mix of the two styles, trying to create some conversation and not just give you facts. And you can think about whether this was a more effective style or not. You'll give us some feedback at the end of the talk about whether you like this approach. And You got some visual aids and infographics. Again, I think ultimately, if you're trying to get to a large audience, doing it in a variety of ways is going to be your best bet. But for our medical audience, the people with some clinical training, data is always one of our fallback positions.
Exactly. I think that was the last poll question. Next slide, please. And I think that's the last slide. And this is the summary slide, and it gives all the information which we try to present to you today. And so the vaccine prevents millions of global deaths annually, and it already prevented millions of deaths in US, and it already prevented millions of hospitalization, more than 18 million. And please, please just concentrate on vaccine hesitancy perspective from the point of cognition, not just for the cognition, from the point of emotions and other features. So remember the left and right brain ones, and everybody is not using the left brain, everybody is not using the right brain. They may have some mixed decisions as well. And also we should develop some styles to convince those people who use left brain and right brain styles. And I think this is very important to figure out which one is which. And we should develop strategies to improve vaccine acceptance with the strong recommendations, personalized education, to figuring out the source of the vaccine hesitancy and acceptance from the point of these cognitive styles. And please also use the presumptive language or the participatory language to increase the vaccine acceptance. So those are the summaries we can share and some bullet points. And we would be more than happy to have some questions through the chat or verbally.
Well, thank you both. That was a great presentation, a lot of great information. Karen, are there any questions in the chat? I know we've gone a little bit over, so we appreciate folks staying with us.
No questions that I can see as of now, but if folks want to, enter a question, we can always get back to them offline.
I do have one question that if you could both sort of weigh in on is what do you feel, just, from your perspective, what do you feel needs to happen going forward to improve adult vaccination rates, both locally on a national level? I know the healthcare provider recommendation is so critical, but do you see a time where collectively we're trying to move these rates, and it's not solely on the provider, although that's most important? I'd just be interested in your perspective on that.
Yasin, go ahead.
Yeah, I think the vaccine clinics in the nursing home is very important, because it's gonna change the habits, and it's readily gonna be very available for the people. And also increasing the vaccination rates can be done by the vaccine clinics, and putting standing orders in the nursing homes will increase the vaccination rates. And the way the Department of Health presents, or the CDC presents, is just for the left-brainer ones. So if we give all this information just with the numbers and the statistical analysis, it's not going to increase. I think this is in the micro level, but from the point of policy and the practical things, vaccine clinics will be the solution, and the standing orders could be a solution, and also reducing the vaccine anxiety. So we should establish a vaccine anxiety educational program for sure, 100%. Yeah.
Yeah, so there's some stylistic things one could do also if one does this in a facility setting or in a pharmacy, where you can have swag and other kinds of things where people get to come around and see somebody else getting the vaccine rather than doing it privately in a room. We've done some vaccine studies where we did this at a veterans home in DC at the Soldiers Home there. And we had a senator come in, and he was the first one in to get a vaccine as we then enrolled people in our vaccine study. And they would get a little hat says, you know, I got shot for you and things like this. Was a veterans home. So seeing this as a point of pride as opposed to a contentious thing, something that you do as part of a community to look out for each other. Those are the emotional sort of right-sided brain things that you can do that I think are helpful. The left side are the numbers, you know, the numeracy and so forth. The right side is this idea that you're doing something for the collective good and not just for yourself, the cocooning and so forth. If you do this again with a staff, you know, privately in a room, that gets lost. So think about how to do this. Having pins to wear afterwards that you can proudly wear, you know, I got shot for you as a pin we've used in the past. And then ask me about my flu shot so that they can have that. So the people who aren't wearing pins, you know, the goal is not to make them feel isolated, but to make them feel like they want to show off too, that they care.
Great perspectives. Well, on that note, we're a little bit over time. We appreciate folks sticking around. I don't know, Ryan, if you can put up the last of our housekeeping slides, but I want to thank Dr. Abul and Dr. Grabenstein for the great talk. It was a lot of great information, a lot to absorb. We will have the recording and the slides to you in the very near future. We just need to get them all compliant as we do so every time we present something. So that will be going out shortly. Just a reminder to visit our WAVE page, our immunization WAVE page. The link is in the chat. This is our vaccine webpage that has a lot of great resources and tools to help aid you in your vaccination efforts. So we encourage you to check it out. Next slide. And finally, our next session for Immunization Awareness Month is on August 27th from 12 to 12:45. What makes a successful vaccine campaign? Thoughts from the field. Registration link is in the chat. We also encourage you to check out our calendar events to view other upcoming sessions that we offer. And then very last slide. I just want to say thank you again to our speakers for their time and attention and all the work they put into this presentation. It was much appreciated. And a thank you to all you on the call. We really appreciate your partnership and commitment to quality. So with that, we will end. I hope everyone has a great afternoon and thanks again.